Hi, everyone, and welcome to a new episode of ASPN Synapse. Today, we have another interview about cerebral palsy and spasticity in upper limb. And we have another expert that we are going to learn from. We have Miss Nathalie, is an occupational therapist and certified hand therapist at Shiner Children's Canada, with a special focus on children with cerebral palsy and spastic hand involvement. She uses the Schreiner Hospital upper extremity evaluation regularly in clinical practice to support the surgical decision making and guide the therapeutic intervention. She also played a key role in developing the spastic hand community partnership, helping to improve early recognition, assessment, and referral pathway for children with upper limb spasticity. Hi, Ms. Nelly. It's a
Hi,
pleasure to meet you.
pleasure to be here.
Thank you. So we want just to warm up first with the first question. And you mentioned that you usually use shoe regularly in your practice. How do you use it in a day-to-day assessment of the children with the hemiplegic cerebral palsy?
Okay, so we use the SHUI to evaluate most of the kids that we are thinking of doing upper extremity surgery or any kind of intervention to help the spastic hand. So in my practice in Quebec, most of those kids have rehab centers, so they're sent to us for assessment of hand for potential surgical decision making surgery of upper extremity. So when we see them, it's part of our first initial assessment. The SHUI is in there, and we assess the deforming force. Once we have the deforming force, then we usually go with first identify the muscle to inject for Botox. And then we do a Botox treatment session. We assist the local therapist in providing the appropriate treatment session post Botox to strengthen the antagonist muscle, of course. And from the follow up assessment with the SHUI again, which is about just under 3 months, where we feel is the peak time and we had enough of therapy, then we reassess and see the impact of Botox and of therapy, and see if the deforming force is much better. Then we have our plan of action for like a possible tendon transfer.
I see. That's very
So
clear
yes, used
pathway.
regularly. If we're unhappy with results, sometimes we just identify another group to inject, or sometimes from the SHUI, it's not even Botox. It's sometimes it's trial of bracing to improve hand function before we go with a trial of Botox. So it actually guides our intervention a little bit.
Yeah, that's very clear. And from occupational therapy point of view, how does the SHUI add beyond the routine clinical observation of the child hand function?
Actually, I find that the more I've been using it and the more the local therapists have been using it, when you identify the deforming force, it kind of guides you on how to improve hand function. We find over the years that the wrist flexion position and even the ulnar deviation has a major impact on the fingers and thumb position and movement. So the SHUI helps you figure out, like, are the fingers difficult to coordinate? Is the thumb in the way? And is the wrist the major reason why the thumb is more adducted or more in the palm? So sometimes with a few just repositioning with your hand, the deforming force, then it helps you guide the therapy in the session. So the more I've been doing it, the more I've been explaining to the local therapists who are unaware of what to do with the SHUI or any kind of like surgical intervention. They kind of see the impact on function quite significantly. And sometimes it's just like putting a tiny little brace to eliminate ulnar deviation and position the wrist, then the patient will tell you, oh, my thumb is much easier to use. So actually guides the whole therapy session, I find. Of course, with all the other assessment, we just,
Mm.
I mean, we not
Yeah,
only use,
of course.
yeah,
Yeah, of course,
yeah,
using that all together. And this
yes.
actually will lead us to the third question. So how do you feel that this helped to decide whether the child needs more therapy or splinting or Botox or referral to a surgical decision?
I find it's the best assessment, in my
Mm,
opinion, to figure out which muscle to inject. In upper extremity, is quite different than lower. Like lower extremity, if you're in clinic, you assess range of motion, you assess tone, you look at them in function, you look at them walk. In terms of upper extremity, yes, you can look at range, yes, look at tone, but sometimes kids have amazing wrist extension ability, but once they're in function, then the wrist is down and deviated. So if you don't see them in function, you don't see the impact of spasticity. So, and in function, you need specific task. And the Shui actually, with some of the things are like strength related with pulling the Play-Doh and stuff like that, which is when you actually see the wrist going down. So it really helps you figure out what to do. And from the shui, usually with the deforming force, if you actually try to reorient or decrease that like spasticity that brings you down with your wrist, you see the impact right away. So I find that sometimes just in clinic, I would just reposition, holding the wrist in a good position, and they right away see it. So they
mm,
want to try a Botox, and they see the plan of this Botox is to figure out, are we gonna eventually rebalance your forces at your wrist to make your hand more functional, or your thumb, or other like
mm. Yeah,
deforming force.
yeah, I got it now. So moving to the next one, which I think
Yes.
is quite interesting for you. So, how did the virtual clinics change the access to the specialized spastic hand care across Quebec?
Uh, Greatly. I mean, there was a big gap in service in children
Mm,
with cerebral palsy over Quebec. So, because of my luck of being in this hospital, surrounded by doctors and being aware of like surgical procedure and having so many years of experience, that I've learned that rebalancing forces does help hand function quite significantly. And in those regions of Quebec where people are isolated, they are unaware of possibilities. So just bringing up like the gap of service was like we would see those kids so much older that sometimes we would lack time because of one Botox and then waiting for the Botox to wear off and another trial of Botox to make sure we do the right transfer. So then this way, I like the kids were seen so late. Like we were like, where are those kids? So we started like teaching the Quebec population and the rehab centers and the OTs about this is possible, this is available, showing them, showing case discussion, like this is the impact of a tendon transfer on your hand function. So this really increased the patient flow coming. We would see them younger. And in fact, what happened with those clinics, the virtual clinics, is we share knowledge. So they gain knowledge, but I also gain knowledge
mm,
because of volume. So the more volume we had, the more we could see that the therapy needs to be way more intense after a tendon transfer on working on reorganizing the neural system, the maturity, and the flexibility of the neural system so that they improve function even more. And then we started using more orthoses to like limit some of these, let's say, hyperextension of fingers, and we can see the plasticity of the brain just changing from like minimal intervention sometimes. So it's been amazing for me, amazing learning, and at the end, it's amazing for the kids.
I see. And this actually started because of COVID, or even before COVID, you started this virtual thing?
This started because of a center close to Montreal who was asking for like knowledge transfer on
Mm,
possibilities. And then from there, I started building some kind of a little learning module on like surgical possibility and how to use Botox. And then it brought up like people knowing about it. And now it's
mm,
like not all of Quebec is done in terms of
mm.
the teaching and the virtual clinics, but a big part of the regions are
It's
done.
already
So.
covered. Yeah.
So it
So,
started by a rehab center need
mm,
and us wanting to like fill in the gap in service with the kids so that we sit them younger and that this is known to everyone. So they have the possibility of actually asking if they're potential candidate for this
Yeah.
intervention.
So this was even before COVID.
I think it started in 2016. Yes, a bit before
Mm.
COVID.
Yeah,
Yeah.
yeah. Okay. So it's not just because of the pandemic, it's just because of
No, no.
the lack of coverage. I see. I got it now.
Yeah, and it's because also because of the distance. Instead of
Mm,
like having everybody come, we would like do those clinics virtually. So the therapists are actually doing the shui and they're
mm,
presenting the shui, and then we say, hey, start with bracing, or
mm,
yes, maybe Botox. And if the
mm.
Botox can be done locally, they do it locally. So we just bring surface closer to home so that they don't have to travel all the way to Montreal. So it just makes it much easier for the family.
Yeah, of course. This is so smart of you.
Yeah.
And how do you use Shui to guide the therapeutic intervention before surgery, especially in goal setting with a child and family?
I mean, it's kind of the same way in a sense that it's goal setting on rebalancing forces. So we look at the forming force, and then we look at the like my intervention is way more musculoskeletal, as you know, in the rehab services they're more socially integrated like services. So we kind of mix and match the both so that we align our treatment. So they integrate like the deforming force in like some strengthening within their own program and
Mm,
goal setting. So it kind of switches a little bit what they do. So people had to a little bit change their practice because they had to include, because they would see the deforming force having a big
mm.
impact on the hand function.
I see. And after the surgery, how do you use Shui or Shui-related observations to guide rehabilitation and measure the meaningful functional changes?
We don't use it as much after. We
Mm,
do use it not like straight after the surgery. We usually wait a good year before we redo a shui. And we would redo a shui if we feel there's still deforming forces that have impact on the hand function. Because I find once we have a surgical plan and then the shui kind of becomes like with results that are nearly full
mm.
where we want. So I mean, it's not as much used after.
I
We
see.
have
So
to
it's,
have more like, because I mean, yes, the shoe is great. You
mm,
reposition forces, but at the end of the day, what you want is goal setting that are like objective for the patient, that is meaningful, that is functional. So we use other tools to measure like functional gain, and those are more used after because the shoe, we once you rebalance it,
mm.
then you have your kind of results.
I see. So it's mainly to guide before the surgery rather than to assist after the surgery.
Exactly, exactly. Well, if
And
we would plan a second surgery, we would use the Shui.
should we again? Yeah, of course.
Yeah.
And in your opinion, what information from the OT assessment is most valuable for the surgeon when he's discussing about operative planning for a spastic hand?
I mean, we always want to make sure that, yes, we look at the deforming force, but we also have to make sure that the functional reason for the surgery is meaningful, meaning like we want to make sure they have like clear expectation of what's going to happen. So this is very important that the family really understands. We also always look at sensation because it does have a big impact on hand function, and that facilitates our ability to have a better prognosis of hand use, so that we have a clear objective so that the family have really good expectation of what's happening. So of course the tone and everything, like we have to do a global evaluation, but I find what's most important for the surgeon and for everyone is that the family and the kid understand the prognosis and the reason for the surgery, so that expectation are met.
Yeah, I
Am I
think it's
answering your
usually,
question?
yeah, of course. I mean, it's usually it's quite hard to match the expectations because usually they have high expectations.
They really do have a high expectation. I find also what I've been doing a lot is sometimes show them similar surgical results so that they really see the impact. I mean, depending on the surgery, we always have to make sure also that we don't impede on function. So we have to have like really clear set goals. If we're not happy with the SHUI, we've always done it, me and the surgeon and the local therapist. If one of us is unclear, we never go ahead. We just redo a trial of Botox. We just
Mm.
make sure that we really all on track and all
All
convinced
aligned.
it's going to work. Yes.
Okay, makes sense. Uh,
Yes.
And for therapists or centers that want to start using Shui, what practical advice would you like to give them to help with use it consistently and clinically, not just as a scoring tool?
Well, I find just like most of the center I've been doing the training, they all had the SHUI because we've been giving a lot of like talk about the shui, so they bring it, but they actually need to understand the hand use and the impact of deforming force on hand function. So I find it has to come with clear examples and because they don't see it. From my experience, in rehab centers, they would be really like geared on function, which makes absolute sense. That's what they should be doing more than musculoskeletal reorienting forces. They don't usually see the impact as much. So I find it needs to come with some kind of explanation and training. And then after that, it needs to come with practice. So I usually tell them, the virtual clinic is great because when I do the virtual clinic is like, let's say it's a center, like they have like, let's say between like 5 to 20 therapists, everybody can join, and
Mm,
all the discussion is made together of like, let's look at this shui, this is a deforming force, this is what you're going to try. So it like the discussion becomes like the volume, like having one patient is difficult. When you have a volume of patient, you see the difference in the shui results, you see the difference post Botox of another patient that you don't know. It helps you understand what the shui can bring you. So the shui on its own is difficult if you don't have all of it that comes, like all the experience and the seeing it. And so I find it comes with time and trying to tell them to stay together, the like to work together as a team and to discuss cases together. The other thing with the shui that's always a challenge because the shui is very simple tool. It's where you videotape it,
mm,
because then sometimes you do your video and then you realize you can't score it because you're not at the right angle. So
mm.
doing it and redoing it and practicing, then you get really good at where to put your video and your
Video.
camera. So it's more of a trial and error, unfortunately, with the shui, that you need to try and understand the shui results
Mm.
and make sense of it.
Is it a steep learning curve?
No, goes pretty fast.
Mm.
It goes
Okay.
pretty fast. I mean, it's quite easy when you see a few cases and then you realize that. I mean, you do one like it guides you with the Botox too. I mean, I find in some of the region here in Quebec anyway, the we have physiatrists which are like orthopedists that are not doing surgery. They just do
Mm,
physical exam, but they can do Botox injection. I find in the upper, they would assess spasticity and inject the spastic muscles. So
mm,
then the therapists are like, what do I do? So it makes it really difficult. So the way we usually do it is more geared which muscle we want to strengthen, what we want to rebalance. So it gives them a clear way of discussing with the surgeon, with the
a physician.
physiatrist, say,
Mm,
hey, let's try a Botox just here so I see the impact.
mm.
And because, I mean, I find over the years, spasticity and dystonia and upper extremity is such a dynamic combo of movement that sometimes too many injection site makes it really difficult to see the impact. So, I mean, it really helps the therapist fairly simply. So, usually my teaching is like, it's a long teaching, it's like a 9 hour, but
Oh,
it usually gives that, yeah, I know,
mm,
because I have many like case discussion and like revision anatomy a little bit, like, so there's like spasticity, it's really
mm.
complex spastic
Yeah.
hand. So,
Yeah.
after that, I do it in a day and then I do case discussion like
Mm.
with the training that like with the teaching there's case discussion in it so that they
Ah,
bring their
okay.
own patient and we discuss their own patient.
Okay, that's very helpful.
Exactly. It makes it really concrete. It's their patient. They did the SHUI, they tried, they don't know what the meaning of the SHUI result is. And as we go along with the teaching and we discuss their like findings, then it makes sense.
Yeah. Okay. That was our last question and the of our interview. It was very a pleasure to us to have you here and learn from you. And all you shared is really very informative for everyone to learn. Thank you so much for your time.
Thank you for having me.
Thank you.
Bye.